Well, good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Serum Osmolality Disorders, Importance, Evaluation, and Treatment. My name is Ryan Muse, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. Now, the webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit your questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel, which is on the right-hand side of your screen. And if you require any assistance along the way, you can contact me at any time by sending a message using the same chat panel. At this time, know that all participants are in listen-only mode, and please note that the event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank Advanced Instruments, who developed the content for this presentation. Advanced Instruments is a global provider of scientific and analytical instruments for the bioprocessing and clinical industries. For more than 65 years, the company's innovations have helped organizations improve quality of results, achieve reliable outcomes, and increase workplace productivity. Clinical labs around the world rely on Advanced Instruments innovations and solutions for delivery of accurate and timely patient results in their clinical chemistry, microbiology, and hematology labs. Now I'd like to introduce our speakers for today's event. Dr. Garode McMahon is a nephrologist at Brigham and Women's Hospital and an instructor in medicine at Harvard Medical School. He specializes in renal disease, and his clinical interests include acid-base disorders, acute renal failure, fluids and electrolytes, general nephrology, and kidney stones. He completed his medical education at University College Cork. And Julie McKenzie, MBA, is a director for the clinical and RTEL product portfolios at Advanced Instruments, LLC. Her background is in biochemistry, cellular and molecular biology, and she completed her undergraduate education at Connecticut College and received her graduate degree from Boston College. But without further ado, let's go ahead and hand the presentation over to our first speaker, Dr. Garode McMahon. You may begin when you're ready.
All right, thank you so much, Ryan. Much appreciated. Appreciate that introduction. Okay, so I'm going to head right into this. So what I'm going to talk about today is the epidemiology of hyponatremia, the regulation of osmolality, the diagnosis of hyponatremia, and the management of our patients that we see who come in with acute changes in osmolality. With a primary focus on low sodium, but I'll briefly mention hypernatremia also at the end. All right, a quick case, and this is a pretty common and typical case of the kind of patients that we see in our emergency rooms with serum sodium disorders. So it's an 88-year-old woman with a history of hypertension, breast cancer, who presents to the ED with a 5-day history of profuse watery diarrhea. She's been drinking large amounts of Gatorade to keep hydrated, and her family noticed that she's becoming increasingly disoriented. In the emergency room, her blood pressure is 96/65, and her heart rate is 96. She's dry mucous membranes, and her ED administers a 500 ml bolus of normal saline and sends routine labs, including a BMP. This is a very typical presentation. The patient's serum sodium concentration returns at 114, and the medicine team are asked to consult regarding the treatment of her hyponatremia. So this is extremely common. We get this consult probably a couple of times a week at least from the ICU service here at the Brigham. And unfortunately, it's not always managed according to best practices. And so I'm going to basically go through the epidemiology of this and how come back to this case ultimately and describe how we would actually manage her in real life. So is hyponatremia important? How many patients get hyponatremia, and why do we have to consider it important for our hospitalized population? So this is a study that was done by Sus Weicker here at the Brigham back in 2009. He looked at 98,000 admissions to the Brigham Mass General between 2000 and 2003. Of those 98,000 admissions, about 80% had normal sodium levels, but about 14% had a sodium of less than 135. So about 1 in 7 people who were admitted to the hospital had a low sodium concentration on admission. The vast majority of those had only slightly low sodium levels in the range of 130 to 134, but about 0.2% of the patients had sodium that was less than 120, so about 166 patients over those 3 years, and 415 in that range less than 124, 120 to 124, which most of us would consider pretty significant. So although severe hyponatremia was relatively uncommon, around about 25% of patients had at least mild hyponatremia. And the question is this actually important and should we be concerned about it? Well, it turns out from the same study, they looked at the effect of low sodium levels on presentation on in-hospital 1-year and 5-year mortality. And it turns out that there was a small but significant association between hyponatremia and all these outcomes in fully adjusted models. So if you had low sodium at admission, even mildly low sodium levels, it was associated with increased mortality both in the hospital and after discharge. In-hospital mortality, however, was lower in patients whose sodium was corrected than those who did not correct, who developed de novo in-hospital hyponatremia. Now, of course, this does not tell us that correcting sodium lowers mortality, because this hasn't been tested here. What it tells us is that if patients' sodium corrects during the admission, they have a better overall survival. And that could be because the sodium has been corrected, or it could be because whatever it is that led to the low sodium in the first place had been corrected, and so that affected their mortality. But it at least suggests that there's a significant association between sodium mortality and between sodium correction and mortality. This is another study that was done also at the Brigham and Mass General, looking at hospitalized patients who were hospitalized for major orthopedic procedures. So these are patients coming in electively for major orthopedic procedures, and it turned out again that there was a significant increased risk of 30-day mortality with both low and high sodium levels on admission. And so there was a U-shaped relationship between the sodium levels and mortality. This is another study looking at, from Ireland actually, this time from, I believe it was University College Cork, my old alma mater, of 1,400 patients who are undergoing routine outpatient DEXA scans. So these are individuals who are well, they are in the community, they have no significant comorbidities that we're aware of, and they were just undergoing a routine DEXA scan, which is a scan for looking at bone density. And 4.2%, so 1 in 20 patients had a sodium of less than 135. And it turns out that if you had a sodium of less than 135, there was a doubling the risk for future fracture in hyponatremic patients versus normal natremic patients. Again, suggesting not necessarily that it's causative in particular, but there may be some factors that are both lowering the sodium and also increasing your risk of fractures. But there's at least some data to suggest that even marginally lower sodium levels are associated with an increased risk of falls, and then that in itself would lead to an increased fracture risk in this older population. So at least I hope I've convinced you, at least to some extent, that hyponatremia is common in hospitalized and non-hospitalized patients. It's associated with a wide range of adverse outcomes, including falls, fractures, mortality. But of course, these epidemiologic data do not prove that correction of mild hyponatremia abolishes these risks, as they could be due to underlying diseases or medications or whatever it is that may be leading to the hyponatremia in the first place. But in any case, it's certainly something that we cannot ignore, because it is both a risk factor for disease, for mortality, and the correction seems to at least reduce the risk of mortality in these individuals. Okay, so I'm going to talk a little bit about the physiology now and discuss the regulation of sodium and osmolality. Our bodies are about 60% water, and the regulation of the balance of water and solutes is vital for life. Our serum osmolality is roughly 280 under normal circumstances, and the predominant extracellular osmol is sodium. Therefore, the serum sodium concentration is a proxy for the serum osmolality. This becomes a bit of a problem in clinical practice. Actually, I'll get back to this after the next slide. Hyponatremia is defined as a serum sodium of less than 135. But in almost all cases, low sodium serum sodium concentrations reflect low osmolality, as the sodium is the primary determinant of the extracellular tonicity. So in general, abnormalities in the sodium concentration are due to disorders in water balance rather than solute balance. And this leads to problems in how you actually explain this to patients and how you think about treating these individuals. And it's one of the most complicated things to teach medical students. Most of the time, the change in the osmolality, or the change in the serum sodium concentration, is due to either addition or subtraction of water rather than addition or subtraction of sodium. And this conceptually is something that people struggle with. And is particularly problematic because we use salt tablets to treat low serum sodium levels. And so if we use salt tablets to treat low serum sodium levels, people ask, why isn't this just a means of giving back salt to people who are depleted? But the vast majority of these patients aren't actually salt depleted. They've just got too much water on board. And that's a really important concept to keep in mind. And so when we talk about the serum sodium level, when we talk about hyponatremia, what we're really talking about is hypoosmolality. It's not the sodium really at all that's the most important part of this. The serum osmolality is tightly controlled and is primarily a function of the amount of water in the body. Hyper and hyperosmolality results from a loss of free water, and hyponatremia results from a gain of free water. Because of this tight control, individuals can become symptomatic with just a 5 to 10% increase or decrease in serum osmolality or serum sodium. And the kidneys are the most important site for the regulation of salt and water balance. The big reason why it is so important for us to regulate urine volume and osmolality are because our intake of fluid and our intake of solutes are not constant. If we took in exactly the same amount of water and exactly the same amount of solute every day, then we wouldn't need to regulate the excretion of salt or of solutes in water because they would be constant in any case. But that's not the way it works. You might drink 2 liters of fluid one day and 1 liter of fluid the next day. And so the day that you drink 2 liters of fluid, your urine needs to be less concentrated than it is the day that you drink 1 liter of fluid, or else your body composition will change. Our free water intake varies according to environmental conditions, social reasons. If you're exercising, roughly speaking, we take in around about 1,200 mils of fluid a day, 1,000 in food or drink, and we produce about 300 mils of water by metabolic processes. So roughly speaking, we gain about 2.5 liters of fluid a day. And then we excrete about 1,500 mils of that in the urine. We lose about 700 mils through insensible losses, which is mostly when we're breathing, about 100 in sweat, and about 200 in feces. And so the balance is roughly speaking 2.5 liters in, 2.5 liters out a day. But it's really important that we're able to maintain this no matter what our solute intake is and no matter what our water intake is. The human kidney can form a urine that varies in concentration from about 50 milliosmoles to 1,200 milliosmoles per liter without changing the amount of solute excreted. So it's extremely effective at changing the concentration. We're not the best creatures at changing the concentration. There are some rats that live in the desert that can increase their urine osmolality up to about 9,000 milliosmoles, which makes sense because they live in a very low free water environment. Renal concentrating mechanism allows us to account for variability in intake and extrarenal losses while maintaining a constant serum osmolality. So if you were to take a person who takes in a normal amount of solute, which roughly speaking is about 600 osmoles a day of solute, that's what we generally take in our diet. The average individual who can concentrate or dilute their urine fully would have to drink more than 12 liters of water a day or less than 0.5 liters of water a day in order to affect the serum osmolality. So we have a huge amount of redundancy built into the system because of the action of the kidneys. And we're able to really remarkably vary the amount of water that we excrete depending on how much we drink. And how do we do this? Well, we use antidiuretic hormone. ADH, which is also known as AVP, which is arginine vasopressin or vasopressin, is a peptide that is similar in structure to oxytocin, which is a hormone used that's involved in pregnancy. It is synthesized as a prohormone in the hypothalamus in the brain and released a lot from the posterior pituitary along with a biologically inactive copeptin. It has a half-life of just 10 to 15 minutes. And we can use copeptin levels as a surrogate for ADH levels. Although I have to say that the number of times that I've measured ADH levels in clinical practice is very, very low. The reason its half-life is very short, it's only 10 to 15 minutes, and that's important because if you have a drink then you need to be able to respond to that change in serum osmolality rapidly. And so if you drink a large amount of water quickly, you need to be able to reduce your ADH secretion so that you will urinate out the water pretty quickly as well. So about 10 to 15 minutes. And if you drink a large glass of water, roughly speaking, in about an hour or so, you'll excrete it all. What are the things that control ADH secretion? Well, serum osmolality obviously controls ADH secretion. ADH is antidiuretic hormone. And so the idea is this is a hormone which reduces the urine output by concentrating the urine. So if your serum osmolality changes, your ADH secretion will go up or down. But very importantly, there is another stimulus to ADH secretion as well, which is extremely important when we're thinking about how to manage these patients, and this is volume depletion. So when patients are volume depleted and when they have the hypotension, you will get an increase in ADH secretion. There are a number of other factors which also increase ADH secretion, including nausea, pain, and a lot of different medications which can influence it also. And AMP and angiotensin II, which are also involved in regulating volume status, will also change your ADH secretion. So first of all, thinking about the osmotic stimulus to ADH release and thirst. Excuse me. So our serum osmolality is extremely tightly controlled under normal circumstances. If you have a normal body volume, you're not volume depleted, then you will have a change in your ADH secretion in response to as little as a 1% change in osmolality. So it really takes very little of a change in osmolality to change your ADH secretion. Below a particular set point, no ADH is secreted. So once your serum osmolality gets below a certain point, then you will not produce any ADH and you will produce an extremely dilute urine. When you take a water load, about 90 to 120 minutes after you take the water, you have your maximum diuresis. This is when all the previously present ADH has been metabolized, and also the aquaporins in the kidney that allow for the water to be excreted are inserted back into the cell membranes. So very small changes in osmolality lead to significant changes in ADH secretion and change your urine concentration. The other factor that controls ADH secretion is your blood volume. A low blood volume pressure also stimulates ADH regardless of the osmolality. And this is because the body prioritizes maintaining your blood pressure over maintaining isoosmolality. There are high pressure stretch receptors in the carotid sinus and the aortic arch, and about a 5 to 10% decrease in blood volume is required to increase ADH secretion in response to hypovolemia. What you'll see here is if you look back at the previous slide looking at the numbers, the maximum ADH here when you have a serum osmolality of about 310 is about 12 picograms per mil. However, when you are volume depleted, you get an increase in ADH secretion which is significantly more than this. So there's a greater increase in ADH levels with hyperosmolality, but it's a more gradual and non-linear response. And this has significant implications for how you manage hyponatremia in the clinic that I'm going to get back to a little bit later. What's important here is that it does take about 5 to 10% change in your blood volume before you start to release ADH in response to this. But once you get significantly volume depleted, then you will start producing large amounts of ADH quickly, and you will start retaining water. For the actions of ADH, there are a number of different places where it acts. The V1A receptors are in vascular smooth muscle and lead to vasoconstriction. The V1B, V3 receptors are in the anterior pituitary and stimulate ACTH production, which leads to aldosterone production and raising blood pressure. And the V2 receptors are in the kidney, in the distal convoluted tubule and the collecting duct, and they increase permeability of the collecting duct to water. And what this does is it stimulates water reabsorption and increases urea reabsorption, both of which increase the urine concentration. All right, so in summary again, the serum osmolality and the serum sodium concentration are tightly regulated. There are small increases in osmolality and large reductions in volume status or potent stimuli to thirst and purposeful drinking. ADH is synthesized in the hypothalamus and is stored in the posterior pituitary and is released in response to increases in osmolality or decreases in volume. In the kidney, vasopressin or ADH leads to water reabsorption. V2 receptors in the thick ascending limb of Henle and the principal cells of the collecting duct, and activation leads to increased water reabsorption from the filtrate into the hypertonic kidney, leading to an increase in the urine concentration. All right, so let's go to a case again. An 87-year-old woman with a history of mild dementia has a witnessed fall at home. 5 days after the fall, her family notes that she's more confused than normal and bring her to the hospital. In the ED, her blood pressure is 134/74 and her heart rate is 80. She appears to be euvolemic, meaning that she's not volume depleted. And her blood pressure is normal and her heart rate is normal, which again suggests that she's not volume depleted. A CAT scan of her brain is performed that reveals bilateral subdural hematomas without a significant mass effect. Neurosurgery consulted and determined that there is no intervention required. Routine labs reveal a serum sodium concentration of 118. Okay, what about the evaluation of these patients? So we routinely order a serum renal panel and osmolality and a urine sodium, potassium, chloride, and osmolality. Medical teams often, unfortunately, forget one or more of these tests. And actually, recently, we've looked into proposing a new test called a basic urine metabolic panel, which would include all of these to allow for better diagnosis and management. One of the problems we have with these patients is that, I often requested teams to serially measure urine electrolytes, but each test in the urine electrolytes has to be ordered separately. And more often than not, at least one of them is left out. Rick Stearns is a nephrologist who's at the University of Rochester and has been pushing this idea for the last number of years, which I think is a great idea, to order a basic urine metabolic panel, which brings all these together, the sodium, potassium, chloride, and osmolality, so that the teams don't have to think about it. And we'll have those numbers every time we actually want to see what's going on with the patients. And so we've recently proposed this here for our lab, and it's going through the approval process at the moment. We're hoping we will have it here at the Brigham within the next year or so. So how do we evaluate patients with hyponatremia? The very first thing you have to do is a serum osmolality. It is key to making the diagnosis. There are 3 different states that you can be in patients with hyponatremia, depending on what the serum osmolality is. Serum osmolality can be low, it can be normal, or it can be high. All right, so what about this case? A 67-year-old woman presents to the emergency department with an altered mental status. Her admission sodium is 116. Plasma glucose is 80. A bright intern checks the serum osmolality and it is 280. The serum triglycerides are 800. This is pseudo-hyponatremia. The idea here is that the serum sodium concentration at admission would strongly suggest that this patient really is hyponatremic and they need to be treated as such. However, the serum osmolality is normal, and that means that there is a problem with the test. Either there is another osmol in the blood, which is increasing the osmolality, or else there's an error in the test itself. And in this case, it's an error in the test due to the presence of pseudo-hyponatremia. This occurs because normal plasma is about 7% lipids and proteins by volume. In a lipemic plasma, it's more, but the lab automatically accounts for this 7%. So if you assume your serum sodium concentration is 140, your plasma is diluted 1 to 10. If half of this was solid, then the diluted plasma sample would only have been 0.5 mils of actual plasma, and hence there'd be less sodium in the sample. The key here is the measurement of the serum osmolality to ensure that this hyponatremia is actually real. Another situation where you might have a false lowering of the serum sodium concentration, or at least one that doesn't need to be treated as a hyponatremia, is in patients with hyperglycemia. In hyperglycemia, because of the osmolar effect of the glucose in the extracellular space, water travels from the intracellular to the extracellular space, and the sodium concentration goes down as a result. As the hyperglycemia is treated, water goes back intracellularly and the sodium concentration increases. Because these patients are generally not hypoosmolar, the usual caution of overcorrection that I'll get back to a little bit later on does not apply. But it's again really important that this is recognized. Now, usually hyperglycemia will be spotted in the BNP when the patient comes in first. But if it isn't spotted, it will definitely be spotted if you do the osmolality and you see that that's normal in these individuals. So again, osmolality in a patient with hyperglycemia or in patients with hypertriglyceridemia can help distinguish between a true low sodium level and a patient who has who has a falsely low sodium level. All right, so this is patients with normal serum sodium levels, serum osmolality, or a high serum osmolality. In the context of a high serum osmolality, it's usually because of an added osmol, and typically this is glucose. With a normal serum osmolality, it is lipids, paraproteins. What about a low serum osmolality? So this is true hyponatremic, hypotonic hyponatremia. What's the next step? To check the urine osmolality. A low urine osmolality in the context of true hypotonic hyponatremia suggests excess water intake. Another case here, 45-year-old man with a history of hypertension presenting to the primary care clinic with a chief complaint of fatigue. Lab results show serum sodium of 129. He's hypoosmolar and euvolemic. His urine osmolality is 90. His low urine osmolality suggests that there's no excess ADH secretion and that the primary problem is excess free water intake. As mentioned before, the normal ability of the kidney to excrete free water is large. Massive free water ingestion drops serum plasma osmolality, no ADH secreted. You get a quick excretion of dilute urine and a recovery of the plasma osmolality. This is unless you have psychogenic polydipsia. But your ability to excrete free water is somewhat limited. You cannot excrete pure water. This would require reabsorbing every molecule of urea and sodium, and so the water has to be excreted with at least some solute. The lowest urine osmolality you can get to is about 50 to 100 milliosmoles per kilogram. And if your solute intake is 1,000 osmoles a day, then the maximum urine output is 1,000 osmoles divided by 50, which is 20 liters a day. If you have a very low solute intake, the amount of water you can excrete is much lower than that. So there are certain individuals where you will have polydipsia, so a lot of drinking, but a low solute intake, and they can become hyponatremic. All right, so assuming that the urine osmolality is high, this suggests that there is increased ADH secretion. Next thing we look at is the volume status. Are they hypovolemic, euvolemic, or hypervolemic? Hypovolemic suggests they're volume depleted. You want to check their urine sodium. If it's high, it suggests that there might be some renal wasting. If it's low, it suggests that they've got extra renal losses of fluid. Hypovolemia, as I mentioned before, is a potent stimulus to ADH. Urine sodium can be a clue to the etiology. High sodium usually means renal losses, so diuretics, hypoaldosteronism, Bartter syndrome, Gittelman syndrome. A low sodium usually means extrarenal, so vomiting, diarrhea, volume depletion. What about hypervolemia? This is in patients with what we call a low effective circulating volume. So these are patients for whom there's a problem with the pump or a problem with vasodilatation. And so the body is sensing low volume even though they're not. Generally, they have a urine sodium less than 20, and it's classically seen in patients with heart failure and cirrhosis. Pregnancy and renal failure may also be associated with hypervolemic hyponatremia, but it's through different mechanisms. Finally, euvolemia. Hypothyroidism, patients with severe hypothyroidism, mixed edema, kind of decreased cardiac output, baroreceptor activation, and a non-osmotic ADH secretion. Mild hyponatremia is not generally a cause of this. Adrenal insufficiency is a relatively common cause of hyponatremia also, due to cortisol deficiency. But the commonest cause of euvolemic hyponatremia is something called SIADH, the syndrome of inappropriate ADH secretion. This is excretion of ADH in the absence of hyperosmolality or significant volume depletion. These patients are usually euvolemic, they're hypoosmolar, their urine osmolality is greater than 200, and their urine sodium is greater than 40, and they may have a low urine sodium. So this is probably the most common cause of hyponatremia that we see apart from low volume. And it's really important to recognize it because it is managed a little bit differently from hypovolemic hyponatremia. Classically, the reason that we see this most often is due to medications. A lot of medications can cause SIADH, mostly psychiatric medications. And so the classic presentation will be an elderly individual who's taking an antidepressant for the first time, and they present with hyponatremia. And it's because of this inappropriate excretion of ADH that occurs in response to the medication. All right, so how do you manage these patients? So the first thing is that the removal of the stimulus to ADH production will lead to rapid correction of the serum sodium levels. And this may seem like a good thing because you're going to fix it quickly, but overcorrection can lead to devastating brain injuries and must be avoided. This is really important, and I have to say that this was the thing that kept me up late at night most of all when I was managing these patients when I was a junior attending, because I worried about this. I would be up half the night checking their labs to make sure they weren't overcorrecting, because it is absolutely, unquestionably indefensible if a patient suffers a brain injury because of overcorrection. That means we have done our job incorrectly. Normal saline has to be used with great caution because it may actually make hyponatremia worse in some patients with SIADH, and it can definitely lead to overcorrection in patients with hypovolemic hyponatremia. So the question is, how can you prevent overcorrection proactively rather than reactively? So just thinking about like overcorrection in general, hypovolemia is really where overcorrection occurs. So hypovolemic ADH release, as I mentioned before, is stimulated by a 5 to 10% decrease in plasma volume sensed by baroreceptors. Even if the total body volume is greater than 500 mils, if you just give this much of the plasma in the form of normal saline, it's enough to turn off this baroreceptor response, because what you're doing is filling up the vasculature, and the baroreceptors sense this and they immediately stop producing ADH. And overcorrection can occur extremely rapidly. So what will happen is you'll notice that the patient's urine bag is now filling with urine very, very quickly, with very dilute urine. And they can correct within a couple of hours. There was a retrospective study that looked at all patients with severe hyponatremia to determine the rate of correction. And over about 10 years at the Brigham and Mass General, there were 439 patients with an initial sodium of less than 115, and 20%, 1 in 5, corrected by more than 12 milliequivalents in 24 hours, which by definition is overcorrection. Why is this important? Well, this is what happens. Under normal circumstances, with your normal brain, you have normal osmolality. When you become initially hypotonic, you have osmoles that are in your brain that aren't in your extracellular space. And so those don't change rapidly. And so what happens when your serum sodium concentration drops is your brain gains water. Your brain then starts to adapt to the low sodium concentration and starts to remove those osmoles from the brain. And so you lose these osmoles, the brain returns to normal again. Unfortunately, if you then rapidly correct the serum sodium concentration, the brain still has an absence of these organic osmolytes, and so you will rapidly get water loss from the brain as a result. And so what that leads to is this condition called osmotic demyelination. It is due to overly rapid correction in serum sodium concentration. It is rare. It can present 1 to 7 days afterwards, and the patients are usually entirely asymptomatic first, but they can get pseudobulbar palsy, quadriparesis, movement disorders, behavioral disturbances. The MRIs can be negative for the first 2 weeks after it happens, but the injury is irreversible. The mechanism is not completely understood. Increase in sodium may cause cell shrinkage, disrupt the blood-brain barrier. There may be direct damage to brain cells, really unclear. But animal studies have suggested that rapid relowering can prevent this neurologic damage. So that is the goal in these patients once it's identified. The goal really is not to let it happen in the first place, but once it does happen, and you get it down quickly enough, it's going to hopefully prevent any injury. So how do we correct hyponatremia? So if it's acute, so if the brain hasn't had time for those osmolytes to equilibrate, then you can correct it quickly. You give hypertonic saline, you raise the sodium level back up to normal level, and you can do this as quickly as you need to. These patients, when I say symptomatic hyponatremia, what this really means is patients with a very low serum sodium concentration can have seizures and can be a kind of altered mental status. And so those would be indications for raising it rapidly. What about patients who you don't know how long it's been going on for? So these are the patients we get concerned about. And so what we've started doing the last few years in these patients is being proactive. We give them all synthetic ADH when they present to the hospital. So what this does is it clamps their urine osmolality and maintains it at a high level so that no matter what we do after that, they're not going to overcorrect. This is a study from 2013, the first study that looked at this, where they took a whole bunch of patients and saw what happened if they clamped their osmolality with ADH on arrival to the ED. And not a single patient in the study overcorrected, which is a huge success when you think about the number of patients that were overcorrecting before. So this is what we do now. If the hyponatremia is of unknown duration with minimal symptoms, we give DDAVP, which is the synthetic ADH, intravenously every 8 hours at the time of diagnosis, start 3% saline, and then plan to increase the serum sodium concentration by 6 to 8 in the first 24 hours, 12 to 14 in the second, and 14 to 16 in the third. We stop everything when the sodium is greater than 130. We check the urine osmolality because, excuse me, if the urine osmolality remains high after stopping the ADH, that suggests the patient has underlying SIDH, and that's going to change the way we manage it in the future. If their serum osmolality is normal at that point, that would suggest that whatever was going on is now resolved. In patients who are very volume depleted, they may need saline also, but once they've had that DDAVP, it's safe to do this because you cannot turn off the ADH because you're already giving it intravenously. For patients who are outpatients, we fluid restrict them, give them diuretics and salt tabs or urea tabs, and hopefully stop the inciting medications because it's usually a medication that causes it. All right, so this is an 88-year-old woman with a history of hypertension and breast cancer who presents to the emergency department with a 5-day history of profuse watery diarrhea. Drinking large amounts of Gatorade to keep hydrated, and her family knows that she's becoming increasingly disoriented. In the ED, her blood pressure is 95/65 and her heart rate is 96, so suggesting that she's volume depleted. She has dry mucous membranes, again suggesting volume depletion. The emergency department administers a 500 bolus of normal saline and sends routine labs, including a BMP. So this is the case that we saw at the beginning of the presentation. And you'll understand now that this is the kind of case that gets me worried because she looks like she's got hypovolemic, she looks like she's hypovolemic, and she's just been given a bolus of normal saline. So these are the patients who will overcorrect, unfortunately. Patient serum sodium concentration returns at 114. Her serum osmolality is 256. So this is a true hypovolemic hyponatremia. The medicine team are asked to consult regarding the treatment for hyponatremia. They check a urine osmolality and it's now 103. And so what's happened here is the patient was initially volume depleted. They had a volume-dependent secretion of ADH. Because we check the serum and urine osmolality, we know that she's got a true hypovolemic hyponatremia, or hypotonic hyponatremia, I should say, and that her ADH is now turned off because her urine osmolality is decreased. And her serum sodium, unfortunately, increased to 131 after 12 hours. She was started on DDAVP and 5% dextrose, and her serum sodium was relowered to 122. After 24 hours, her DDAVP continued, and 3% saline was administered to raise her sodium slowly to 130. Hypertonic saline and DDAVP were stopped, and the patient settled out at 136 after 4 days and was discharged. So this is the kind of situation, this is where it's well managed after the initial overcorrection, but this is what we're trying to avoid with our newer protocols. There's another case. An 87-year-old woman with a history of mild dementia has a witnessed fall at home. 5 days after the fall, her family notes that she is more confused than normal and brought her to the hospital. In the ED, her blood pressure is 134/74 and her heart rate is 80. She appears euvolemic. Her CT brain is performed that reveals bilateral subdural hematomas without significant mass effect. Neurosurgery field is nothing to be done, but her routine labs reveal a sodium concentration of 118 and a serum osmolality of 260. So again, a true hypotonic hypovolemia. Although SIDH is likely, there's a high urine osmolality and a high urine sodium, there may be a hypovolemic component, so DDAVP and 3% saline were administered. Her serum sodium increased with improvement in her neurologic status. Her serum sodium went from 117 to 120 to 128 to 132. Her urine osmolality went from 609 to 730, 744, and her urine sodium plus potassium were 123 to 120 to 140. So again, what we're seeing here is persistently high urine osmolalities in the context of a correcting serum sodium concentration, suggesting that she truly has SIADH. Once the sodium was normalized, she was started on salt tabs and fluid restriction and continued with regular monitoring of her urine osmolality to determine if the SIADH had resolved, which was likely because of the brain injury. So for the last couple of minutes, I'm just going to very briefly touch on our hypernatremia algorithm. And again, it speaks to the importance of measuring osmolality in these individuals and why it's key to making a diagnosis. So again, hypernatremia, high serum sodium concentration. The first thing you need to know is why it's happening. And how you're going to determine that, initially at least, is by measuring the urine osmolality. In a patient who's hypertonic, they are either losing too much water or else they are taking in too much salt. But taking in too much salt is a much, much less common cause of this. So you measure this urine osmolality. If the urine osmolality is high, which it should be, if you're hypertonic, if you've got too little water on board, your urine should be extremely concentrated. And if it is, that suggests that you've got extrarenal water losses, GI losses, insensible losses, and decreased water intake, no access to water, or adipsia, which is a lack of thirst, which is pretty rare, but I've seen it a couple of times. No access to water is really important here as well. Personally, I feel that a patient coming from a nursing home with high serum sodium levels and a increased urine osmolality means that they're not being treated properly in a nursing home, and it's a way you need to look for neglect because they're not getting enough free water. If urine osmolality is low, it suggests you have renal water losses. This could be either due to an osmotic diuresis in the context of glucose, urea, or mannitol, or diabetes insipidus, which can be central or nephrogenic. But again, it speaks to the importance of osmolality in making an accurate diagnosis in these individuals. I think I'm just coming up on time, but so key takeaways: sodium disorders are common, particularly in hospitalized patients, and are associated with significant adverse outcomes. Hyponatremia is generally due to excess water, leading to hypoosmolality. Measuring serial urine and serum electrolytes and osmolality is key to diagnosing and treating hyponatremia, in particular to avoid overcorrection and neurologic damage. And the proactive use of Vasopressin can prevent overcorrection in cases of severe hyponatremia. Thank you very much for your attention. I'm going to pass it over to Julie McKenzie now.
Thank you, Dr. McMahon. Hello, everyone. I appreciate the opportunity to talk to you all today. Osmolality is an important test with many use cases. Dr. McMahon discussed two very important use cases, both hypo and hypernatremia. And now I'm going to touch on the technology used to measure osmolality. This is called osmometry. The gold standard method for measuring osmolality in clinical labs is called freezing point osmometry. This method takes into account all osmotically active solutes in a solution, including volatiles or alcohols. And this is really critical in several key use cases. So picture common use case: a patient presents to the emergency room, the physician suspects alcohol intoxication, whether intentional or accidental. He or she will order osmolality to look for something that we'll talk about in just a moment called the Osmolal Gap, which includes a measured osmolality result. Another use case may be that a patient has suffered trauma and they have cerebral edema, and the physician wants to administer an osmotically active drug therapy like mannitol, so sugar alcohol. It's really critical with freezing point osmolality that that's the device being used in the lab, because volatiles and alcohols interfere with another osmometry method called vapor pressure osmometry. really critical for the method to be freezing point. It's also important to acknowledge what's called calculated osmolality. So this is a calculation that's obtained from a general chemistry analyzer, and calculated and measured osmolality may be similar, but it's important to know both calculated osmolality and measured osmolality by freezing point depression. It's really those cases when calculated and measured osmolality are not the same that are so important, and exactly why you want both. Without both calculated and measured, you wouldn't know the osmolar gap. And that's the difference between the measured and calculated osmolality. It really gives physicians important information about what's going on in the patient's body. For example, is a foreign substance like alcohol present, and guides treatment. Generally, osmolality is performed in-house, an in-house test on a freezing point osmometer located in the clinical laboratory. That does a few things. One, it gives control over the method that's being used to ensure that freezing point osmometry is used. In addition, it helps minimize any sample evaporation that may take place after collection. And that's really critical for result accuracy. The longer you wait to test that sample, the potential for evaporation. So really important to have that instrument on site. The other, of course, is the physician need. The physician has ordered osmolality because he or she needs that test quickly to make treatment decisions. So now if we look at the science of what's happening underneath the hood of a freezing point osmometer, so we're looking at this graph here. We have time on the x-axis and temperature on the y-axis. We'll follow our sample through this process. So you'll see first the instrument cools the sample well below its freezing point. Freezing point here is that blue dotted line. Freezing is initiated. And you may be familiar with the knock of a solenoid or the buzz of a stir wire that makes that noise. Recent advances in osmometry, however, where we're using a thermal block to freeze a sample, you actually have no sound. As the sample freezes, the heat of fusion is released and warms the sample towards its equilibrium freezing point. And once the sample, or temperature rather, reaches a plateau, the result is reported on the osmometer in terms of milliosmol per kilogram. Freezing point osmometry, it's something that's been around for a long time, which is interesting in the context of Dr. McMahon's presentation, where, even though it's been around for a long time, best practices aren't always followed. It's been around even longer than shown on this slide here. So while the method's not new, there have been several advances in technology over the years. Many of these advances are around ease of use and automation as we shift to the present time. We'll talk about this a bit more, but when it comes to being able to load primary tubes instead of having to pipette samples, automatic duplicate measurements, really best practice in the labs, and taking that off of the tech's plate, having the system do that automatically, as well as automatic sample ID scanning and LAS connectivity. Really, it's about making osmometry more accessible to techs of varying skill levels, freeing up tech time, improving result turnaround time, and reducing errors. And that's so critical in the current landscape where staffing challenges are rampant. So really some advances there, while the freezing point method really remains tried and true. So wanted to end with an example of a recent advancement in freezing point osmometry, and that is flow-through freezing point technology. So traditionally, freezing point osmometers have required pipetting into plastic sample test cups or tips, and then the sample is frozen within that piece of plastic. The user then discards and replaces the plastic and reloads new. What's interesting about this advancement in technology with flow-through is that the sample is actually frozen within a module in the device, eliminating the need for that plastic test cup and tips. So picture this, the user loads one or multiple primary tubes, really could be used as a single or multi-sample osmometer. An automated pipette comes down, aspirates the sample, pulls that sample into the freezing module. The sample is then frozen within the device. to then pumped out, and cleaning is automatic between samples. So several benefits here. One is ease of use. If you think about the staffing shortages today and the situation at hand, eliminating that manual pipetting really drives a lot of value, minimizes the impact of staff experience level. And I would say, to be honest, takes the burden off of the tech. He or she, they have so many things to worry about. Pipetting, into an osmometer shouldn't be one of those things. So really improving accuracy, reducing risk of errors, taking the burden off of the tech and putting it on the technology where it really belongs. Really what that does is it frees up tech time, helps enable faster turnaround times, which is so critical in the context of Dr. McMahon's presentation, where physicians are really relying on these results to make treatment decisions. Another advancement in this technology is the small footprint. So because you've eliminated the plastics in the test cups, that real estate that would be needed with the instrument is gone, and really makes devices more attainable for labs of all sizes, not just high throughput laboratories, because the reality is smaller laboratories are just as challenged with staffing. And so really it's about making automation accessible and attainable for everyone. And then also importantly, thinking about the environment and reducing plastic waste, flow through freezing point technology helps there. So really the key takeaway here is that, yes, freezing point technology has been around for a long time. Indications that, best practices aren't always followed, and there are cases of underutilization. And then that there have been significant advancements in the technology that help combat staffing challenges today. So I want to thank everyone so much for your time and attention today. At this point, I'm going to kick it back over to Ryan. We'd love to take some of your questions.
Well, thank you very much for that insightful presentation. I would like to at this point invite the audience to continue sending their questions or comments right now using the questions window for this Q&A portion of the webinar. Now, I've already received some questions, so we'll get ourselves started with those. The very first question that I have for you would be directed towards Dr. McMahon. I would like to know, in theory, what percentage of patients with hyponatremia should receive osmolality testing? And what percentage receive osmolality testing in practice?
Well, my sense is that everybody should. I don't think there's any question about it. I use it routinely in clinical practice myself, and I use it multiple times, so it's not just one test and done. I have had a number of patients for whom the initial impression of a hypovolemic hyponatremia is incorrect, and you don't realize it until you've checked the serial urine osmolalities over a number of days and see the osmolality remaining high or the serum sodium increasing. And so my sense is we should be doing it more often than we actually are right now.
Very good. All right, thank you. The next question here is wondering, how long is a serum osmolality stable in open cap sample? They say a lot of doctors like to use add-ons to osmolality, so should we do add-ons?
I could take that one, Ryan. So I'm not aware of stability studies on uncapped samples. I do know that we've done studies on capped samples, and really the recommendation, well, there is some stability, recommendation to test as soon as possible because of evaporative properties of samples. And when you are thinking about osmolality, where it's an overall concentration measurement as opposed to looking for a specific analyte, testing that sample quickly is important. It's one of the reasons that we recommend testing samples in-house to minimize that time since collection. Also, of course, because physicians rely on that information. So we don't dictate whether or not to do add-ons, right? Ultimately, the physician needs the test. We leave that to the physician in the lab to work out. But I think it is interesting when you think about the basic metabolic panel that Dr. McMahon mentioned, and how do we ensure that if the physician needs an osmolality test, he or she gets that up front. And I think that's an interesting way to ensure that that happens.
Very good. Thank you so much for that answer. The next question asks, how does specimen viscosity come into play in the flow-through technology? Are the specimen requirements different from A20 instruments?
Ryan, I can take that one too. So it's a good question. So the flow-through technology is currently validated for serum, plasma, and urine samples. Additional fluids will be validated in the future. Things like stool, for example, may require filtration, other body fluid types, but those main body fluid types, the serum, plasma, urine, all validated for both the A2O as well as the flow-through methodology.
Wonderful, thank you. Next, then, someone wonders, what can the medical community do to help ensure appropriate utilization of tests like osmolality in cases of hyponatremia?
I think, education is the most important. I see as I'm an evangelist for this. I talk to the medical residents, talk to the students. We do our course, our renal pathophysiology course, and we highlight this every year, just because it's the best way to understand what's going on. In these patients, the more data we have, the better. And so it's all about education.
That's good to know, thank you. So then you mentioned that you and others have proposed a basic urine metabolic panel that includes osmolality testing. Can you elaborate more on how that will work?
Yeah, so this is essentially a way of just making, as I mentioned in the talk, it's a way of making sure that people do the testing fully rather than doing individual components. In the same way as we have a basic metabolic panel in the blood, nobody ever orders, or very rarely orders, the sodium on its own. They order a basic metabolic panel. And so it's become accepted practice to do this. And so our hope is that over time, it'll become accepted practice to do a standard basic urine panel also. Because again, it'll ensure that all the tests are done appropriately every single time.
Very good. Thank you so much for that answer, both of you, and for all of your answers. However, we have reached the end of the Q&A portion of our webinar today. Now, if you're going to attend to your questions, though, the team at Advanced Instruments will follow up with you, or if you have further questions, you can direct them to the email addresses that are up on your screen. I want to thank everyone for participating in today's webinar. You will be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen as you exit, and your participation is appreciated as it will help us to improve our webinars. I've also sent you a link in the chat box, and with this link, you'll be able to view a recording of this event on this page, and you can also share this link with your colleagues when they register for the recording here as well. So I encourage you to do that. Now, please join me once more in thanking our speakers for their wonderful time here today. We hope that you all found the webinar informative. Have a great day, everyone, and thank you for coming.
Thank you, everyone. Thank you, Ryan.
Thank you, Ryan.